Hello, I'm Kristen Radke. I'm one of the PGY5 anesthesia residents at the University of Alberta. And one of my passions is point-of-care ultrasound, specifically lung ultrasound, and these are my notes for the busy anesthesiologist. For this presentation, I will assume that you've had some exposure to lung ultrasound previously, perhaps during your training. I will very summarily review the most high-yield lung ultrasound artifacts, and thereafter I will introduce you to the blue or bedside lung ultrasound in emergency scanning protocol, with one small modification I introduced to improve workflow and speed without sacrificing accuracy. I'll run through a short demonstration of what a blue scan might look like, and lastly we will review the blue protocol in terms of diagnostics. I typically like to start my presentations with a clinical vignette. In pre-op, you have a 76-year-old lady with a history of emphysematous COPD and HFrEF, presenting for unilateral mastectomy for breast cancer. The patient states that she started to feel dyspneic when she woke up with a coughing spell this morning. Her vital signs are heart rate 121, blood pressure 105/52, saturations in the low 80s on room air, respiratory rate 28, and temperature 37.8. With the ambient noise, your auscultation is difficult, and a portable chest x-ray won't be available for at least a half hour. Your initial differential diagnosis includes some of the most common causes of acute respiratory failure in adults: COPD exacerbation, pneumonia, pulmonary edema, pneumothorax, and pulmonary embolism. Like most surgical suites, you have immediate access to an ultrasound machine, and you're about to get to know the blue protocol, which is designed to provide rapid diagnosis for each of those conditions in acute respiratory failure. In any lung ultrasound, the first thing you look for is lung slide by the shimmer at the pleural line or seashore sign in M mode. Presence confirms ventilation in that section of lung. Absence could be pneumothorax with a barcode sign. It could be pleural adhesions and inflammation due to ARDS or pneumonia, or it could simply be a lack of ventilation, such as in a mucus plug. Remember in pneumothorax to look for lung point by gliding the probe laterally on downwards towards a stretcher. You should see the leading edge of the lung sliding into and out of view. For A-lines, remember that these mean that there is mostly air below the pleura, such as in a normally aerated lung or in a pneumothorax. B-lines represent mainly interstitial disease. In emergencies, we usually think of either edema, be it cardiac or ARDS in nature, or interstitial pneumonia or pneumonitis. Note that B-lines rule out pneumothorax. And lastly, there's consolidation, which can present either with a Swiss cheese looking lung, as you can see there, or with C-lines, which really just look like very fat B-lines. If any of these artifacts bring only very vague bells, I highly encourage you to review them after viewing this presentation. These artifacts form the basis of any lung ultrasound, including the blue protocol. So why the blue protocol? Well, for one, it is designed specifically for patients in acute respiratory failure. It provides excellent diagnostic accuracy for the diseases in our initial differential diagnosis, both in positive predictive value and negative predictive value, as you can see here. The blue protocol's accuracy has even been shown to be superior to that of physical examination plus chest x-ray, and it should take less than 3 to 5 minutes to complete. As I alluded to earlier, in my own practice, I do modify the original protocol slightly by switching the order of 2 of the steps. The blue protocol only has 3 points per hemithorax to scan, so 6 in total. There's the anterior or upper blue point, the anteromedial or lower blue point, and finally the posterior or PLAPS point, which is generally as far behind the posterior axillary line as the bed will allow you to go at the level of the diaphragm. Lastly, in one type of circumstance, you will have to scan the legs for DVTs, which I'll cover in the next slide. So what does this look like in action? You start by scanning the 3 points that we just talked about, the upper, the lower, and flaps on each hemithorax, while looking for lung sliding and taking note of whether you see mainly A lines, B lines, or consolidation. In this case, we have lung sliding everywhere. We have primarily A lines with a few B lines. In general, I like to keep a depth of around 10 centimeters in most situations, unless I'm looking at lung slide as I am presently right now, when I will usually go around 6 centimeter depth. I increase the depth for the flaps points to maybe about 16 centimeters or so. All in all, it should take about a minute to a minute and a half to do a scan for both lungs. Perhaps a little bit more if you're having to move the blankets and gown. Usually at this point, you're done. In 2 situations, you'll have to take just one more step. You may have to look for a lung point in pneumothorax. And if the lungs look entirely normal, then evaluate the likelihood of pulmonary embolism by scanning for DVT. This is actually really quite simple and short. On each leg, scan the femoral vein and popliteal veins, ensuring collapsibility. In this case, I'm scanning the patient's right leg. Obviously, you would do this bilaterally. This scan in particular is relatively thorough, and it still doesn't take too long. The key at the femoral veins is to look at the branch points, since that is where clot tends to accumulate. So if we remember our little vignette, we've got a patient with a very wide differential diagnosis with vastly different treatments. Let's see what happens if we use the blue protocol. So we start by scanning the lungs, looking at those 3 blue points. We look to start with if there is any lung slide. Let's say there is no lung slide. If we've got primarily A lines below the pleura, then we look for lung point to diagnose a pneumothorax. If we cannot find a lung point, she could either have a massive pneumothorax obliterating that whole chest cavity, or she could just have a segment of lung that is not ventilated. Think of a mucus plug, or if this is an intubated patient, a main stem intubation could give you this pattern. If, on the other hand, she's got primarily B lines, this is most likely going to be pneumonia or ARDS with some pleural adhesions. It does rule out pneumothorax though. If now we do have lung slide, if we've got primarily B lines and they're diffusely scattered throughout the lung, this is most likely pulmonary edema. If we do have lung slide, no B lines, primarily A lines, look at the flaps points. Pneumonia likes to hide here, as does COVID. If the flaps points are also clear and the lung looks largely normal on ultrasound, you've now established that the pleura and interstitium are likely intact and not the cause of Our Lady's hypoxia. Your last step is to evaluate the likelihood of pulmonary embolism. Look for DVT, as mentioned just before, and if positive, this is a pulmonary embolism until proven otherwise. If negative, this is some larger airway disease such as asthma or COPD. That's it. The entire protocol all put together looks daunting, but if you break it down, it's really not so bad. All in all, with just a little bit of practice and understanding of the main lung artifacts, this should take no more than 5 minutes before you can start to more effectively and accurately treat the common and dangerous causes of your patient's respiratory distress without having to wait for other imaging. I encourage you to be opportunistic and practice this technique when occasions present themselves. Lung ultrasound is almost as quick to learn as it is to execute and is very high yield. For a more in-depth look at any of the ultrasound concepts and artifacts mentioned in this presentation, I invite you to explore the Alberta Sono website at absono.ca. Thank you for your attention.